Very excited to be here with you. We're pleased to join everyone today to have this very inspiring conversations about military medicine and the hidden costs of war. And we're very excited to be joined by Dr. Tanisha Fazal. My name is Ariela Blatter, and I'm the President and CEO of Women in International Security, also known as WIIS. WIIS is a non-governmental organization that looks to advance gender equality through promoting women as leaders in the international peace and security environment. For over 35 years, this global organization has provided professional growth opportunities for women through mentorship opportunities, through events like these, and through research opportunities. And we come together as a network of scholars, leaders, and key researchers together to look to achieve the opportunity of closing the global gender gap, which unfortunately, since COVID, has expanded. Our network today spans nearly 56 countries in over 6 continents and with over 15,000 members. And if you are not one of those, we welcome you to join us by going to www.wisglobal.org. I'm now delighted to welcome Dr. Karen Johnston, who is our moderator for today's event. Dr. Karen Johnston is the research director at WIIS. She also is an adjunct professor at the School of Public Policy at the University of Maryland College Park and at American University. She's a recipient of the U.S. Department of State's Franklin Fellowship, and she previously served in the Bureau of State's Conflict Stabilization Operations, focusing on the security sector portfolio and stabilization strategies. Please, Karen, the floor is yours to open the panel.
Thank you very much. It is my pleasure to welcome our panel today. I think it's a very, very important issue. And let me introduce them first, and then we'll have a couple of comments. Dr. Tanisha Fazal, professor at the University of Minnesota. We have Dr. Tracy Perez-Colmos, who is the professor and director of doctoral programs in preventive medicine and biostatistics, and the director for the Center for Health Services Research at the Uniformed Services University of Health Sciences. Finally, we have Lourdes Tiglao, who is the executive director, Center for Women Veterans in the U.S. Department of Veterans Affairs. And if you're interested in learning more about their bios, we can put them in the chat for you, where they have a little bit more extensive information about all of their experiences and their expertise. Let me just begin by saying a couple of things about Dr. Fazal's book. As she shows in her book, wars have become increasingly survivable for wounded troops because of medical advancements developed in the field of battle, to the point now where a large majority of wounded soldiers survive. As she argues, these improvements have significant financial and deeply personal implications for the returned wounded and their families, as well as the U.S. government and its citizenry. We will take a look at these developments today and the gendered impact for women soldiers and veterans in our discussion today. So I welcome our comments first by Dr. Fazal, and then we will have a couple of questions for our speakers, and then we will have a larger discussion with our audience as well. So, Dr. Fazal, thank you.
Thank you. Thanks so much, Karen. Thanks to WIIS for hosting this event and for all of you for being here. I just wanted to take a moment and say that the WIIS Summer Institute was the first conference I ever attended as a graduate student back in the late 20th century, but the 20th century nonetheless. So it's a particular pleasure to be here today to talk about this book. And what I thought I would do is start by giving kind of an overview of the book and then take us through the argument with a gendered lens to see how the argument plays or develops in those terms. So just to give a sense of the arc of the argument of the book, the basic argument is that in the United States, dramatic improvements in military medicine, alongside historically the expansion of the veterans benefit system, especially since World War II, have increased the long-term downstream costs of war in ways that we just haven't tended to appreciate. So as a percentage of those deployed, because of better medicine, we have many more people returning home today than we did in the past. And those people are also returning home to an expanded veterans benefit system. But because we don't think about the long tail of the costs of war, on the front end, ultimately, and this is really the most important takeaway from the book, we're systematically underestimating the cost of war. So to maybe put some numbers to some of these claims, this is a chart of the wounded to killed ratio for the United States since the founding of the Republic. Now, the wounded to killed ratio is a very commonly and well-known used statistic. Historically, it's hovered around 3 to 1. So for every person killed, you'd have about 3 people wounded. And you see here that for the US, it's kind of drifting up over time and then really shoots up in the most recent wars in Iraq and Afghanistan. And I'm happy to talk about why, to really get into the specifics. But the reason, a lot of the reason has to do with improvements in military medicine in these wars. But what this chart doesn't show is changes in treatment of diseases, because this is really just looking at treatments of injuries. And this is another really important aspect of the development of military medicine, something I spend a lot of time in the book talking about. And I wanted to take a moment here and talk about this historically beginning in the Civil War, because this is the case that I start with in the book. It's kind of a baseline case, because if you want to make an argument that costs are increasing, you need to start from somewhere. So I start in the Civil War. And here disease is especially important because, of course, we're talking about a war in the mid-19th century. It's the pre-germ theory of disease era. So there are a lot of things. It's actually very frustrating to do the archival research on this war because you just want to kind of scream at all of these military and medical personnel for not understanding all sorts of things, like why is it that patients recovering outside do better, or why is it that the coffee tastes different if you're downstream from where the horses are stabled, right? So these are all these things that were noticed but not really understood. And a lot of times people describe Civil War military medicine as medieval. That is actually the term that's used. And there is definitely something to that. But at the same time, it's important to note that in every war, medicine improves. And that is also true in the context of the Civil War. But the major improvements in the Civil War happen really more on the front of medical infrastructure or medical logistics. So we have the standing up of an ambulance system, for example. And in particular, during the Civil War, another important change has to do with the standing up of a hospital system. Because in the mid-19th century, hospitals in the US were just not a thing. If you were sick or if you were injured, you were tended to at home by the women in your family. But because of the scope of the Civil War, they had to stand up these military hospitals in order to treat people and return them to duty. And what that meant was that all these who historically had taken care of their family members at home shouldered their way, really forced their way onto the battlefield and into these hospitals. And so you had women like Dorothea Dix on the left and Marianne Bickerdijk on the right. Louisa May Alcott was also, the author of Little Women, was also a nurse in the war. If you go to one of the entrances to the DuPont Circle metro station, you'll see etched into the wall a quote by Walt Whitman, who was also a nurse in the Civil War. And so you see women really starting to play an important role in improving military medicine in the context of providing care. And we should also note that nursing for women in the Civil War was critical because it created an opening for a profession where you could actually work outside the home. Of course, are also recipients of healthcare, not just providers of healthcare. And one way to, and there's a connection between these two components, because when we get to World War II, for example, there's an enormous demand for nurses, and the rule was that only women could be nurses. So even if you were a man and you were a nurse in your civilian life, you could not serve as a nurse in the military. Only women could be nurses. But so you have this rule and you have this demand, but you have a military that's entirely unprepared to provide health care to this constituency. I mean, to things from menstrual products to shoes. But again, you see a lot of learning during the war. And you see health care for women improving, although always there are inequities. And we see that as well in the context of military sexual trauma, which is something that I think Tracy in particular can speak to very effectively. So, so I'm not going to spend a lot of time talking about this, but I will say that it's a much harder issue to deal with than shoes, obviously, and also it's not only women who are victims of military sexual trauma, but this is an issue that really gains attention because of the expanded role for women in the military. And preventing military sexual trauma would actually reduce costs both in service, for women in service, and on the veteran side of things. So this is something that really needs more attention. So women, as recipients of healthcare, are exposing inequities and giving more exposure to other issues, but also benefiting, of course, from all the other improvements in military medicine, from treating disease to addressing hemorrhage. And because of these improvements, more people coming home, right, which means more veterans. So the history of veterans benefit in the U.S. is a really fascinating history. It kind of goes up and down until you get to the point of World War II, and after that, veterans benefits just increase almost monotonically. And you see here on the left a clip from some of the archival research that I did. There was a lobbying campaign for the GI Bill, and you'll notice that it was originally called, or generally referred to as the Bill of Rights for G.I. Joe and G.I. Jane. We don't think of it that way anymore. It's kind of an erasure of G.I. Jane, notwithstanding the Demi Moore movie. Shout out to my Gen X peeps. But it again sort of demonstrates, it's emblematic, gives us a hint of how difficult it was for women to access some of these benefits. But that is also something that has changed over time. Not as much as it needs to, but has changed. And this is something that Lourdes can talk about as well, because today the VA system has really made significant efforts to stand up benefits for women. But just as broadly, the cost of veterans benefits over time, you see again this almost monotonic increase in veterans benefits or cost of veterans benefits. All right, so we have better medicine, more people are surviving, better benefits. So what this means is that we have higher costs, but we don't think about these costs. When we think about how much it costs to go to war, these are not the costs that are front and center, but it's most of what we're paying for today when it comes to the Afghanistan and Iraq wars, for example. So I want to take a moment to think about why we don't think about these costs. Part of it has to do with the way that the public considers casualties. Almost always there's sort of an equation of casualties with fatalities, but with better medicine, you have a real shifting of casualties from the fatal to the non-fatal column. We also just don't have a very good system in the government for costing out war. This is at a very high level, and this is something that has been true historically. So on the right here, you see a screenshot of one of Don Rumsfeld's snowflakes, the emails he would send when he was Secretary of Defense. And this is a few days after OEF starts, and he's saying to the comptroller, well, maybe we should figure out how much this war is going to cost. Which is really makes the point, I think, very well. But insofar as we do have systems to cost out war ahead of time, these systems don't anticipate that there are going to be improvements in medicine and quite possibly expansions of the veterans benefits. So again, we're systematically underestimating the cost of war. So what should we do? I'm going to hope that Tracy and Lourdes talk more about the policy, but I'll just throw out a few ideas. One is that I think that the U.S. should have a better system of costing out war, full stop, for one. Two is that we should definitely be including expected medical advancements in these costs. And three is that, you could make the argument that if something is improving the cost, then you should stop doing that thing. It's not at all what I'm arguing. Nobody would argue that we should roll back the medicine. I think instead we should double down on the medicine because it has positive effects in terms of military effectiveness. There's a very strong relationship, and this is work that Tracy and I have been doing. And also, at the same time, there's a lot of research that demonstrates that when you have inequitable treatment and inequitable results when it comes to healthcare that ends up reducing effectiveness. And so at the same time that we double down on medicine, we also have to double down on addressing some of these inequities, including, of course, the gender inequities. So I'm going to stop there and turn it back over to you. Thank you.
Thank you very much. I'm going to just turn it over to Dr. Tracy Colomos, and there's so many questions that we can address. Right? What are the key disparities? What are the key health issues? What are we missing? And you've worked with Dr. Fazal as well, so I welcome your comments on the book and then giving us your perspectives also on some of the issues that are been brought out and that are important for our discussion.
Awesome, thank you. And I'm assuming the mic's on so that they can hear. Awesome. That was such a great summary of your book, which I read and thoroughly enjoyed, and not just because we've been doing research funded by the Department of Defense that's adjacent to the book. I do want to share with you when this is done, there's a beautiful graph that came out in Politico that not the whole scope and cost of the VA, but it compares the cost of the military health system, which sort of leveled out in 2011 at about $53 billion a year, against the cost of the VA healthcare system, which has gone up and really kept pace with national growth in the cost of healthcare. So it's a great graph. I think you will enjoy it, and I bet you roll it into future presentations of the book. I know that we're being very gender focused, both about our research and also that we've done together, and your book, and looking at the status of women in the military. I think what's really important for everyone here, maybe you all know this already, is of course all jobs became available to women in the military with the lifting of the ground combat element exclusion on the 1st of January of 2016. I was working for the Commandant of the Marine Corps in the years leading up to that, and that work was like a side hustle from a much larger healthcare task, and I think it was the research skills, not anything else about me that would have put me on like the women workforce issue. But women now constitute almost 20% of the active duty force, which is different from when you and I served in the last millennia. So we have to look at health and meeting the healthcare needs, whether it's preventing injury, helping to address reproductive health needs. So a lot of people will focus on the prevention of pregnancy, but really our very healthy, well-insured population, what we need to talk about instead is avoiding unintended pregnancy so that young women can glean the benefits of service, get those educational benefits and those career opportunities that become more challenging when you deliver a baby that was not part of your plan in your first several years of service. And so we've done a lot of research looking, and there's been a tremendous amount of work across the DoD looking at the stand-up and easy access and availability for family planning and contraceptive issues. But we're just embarking with the VA. Our first meeting is Friday, looking at what happens at the other end of the cycle for active duty service women. Now that there are so many active duty service women, there's more women in the total force of the Army than there are Marines in the Marine Corps. So think about that for a minute. So there's a lot of women, and now we're seeing where a lot of women are staying in and enjoying full careers. So on Friday, the DoD and VA menopause working group will meet for the very first time to look at issues like who's getting a mental health diagnosis, who really could use a little hormone replacement therapy instead. So we're starting to look at the whole woman, at the whole life course to allow women not just to fly all the jets and serve in the infantry and drive tanks, but rather to enjoy full health and taking this population that used to be very small and serve, again, primarily in healthcare, but allow them to experience their work fully.
Yeah, and let me piggyback a little bit on that one. So you asked a little bit about some key disparities in regard to healthcare, and speak from the side of the women veterans. And some of the disparities really come towards gender-specific care. It's only until recent years that we've been able to actually really focus and give a lot of energy and effort and resources towards gender-specific care. And that's part of the reason for that is that the Veterans Affairs historically, from its origins, was built for men because women weren't allowed to serve in the first place. And so there's a lot of historical overtures and reflections for what the system looks like today. However, VA now is really striving hard to make sure that the services, the provisions of care that we provide, as well as the way that we access and the way that we provide access and provide communications, making sure that it's resonant to the different constituents that we have. Not only from the gendered lens, but also from an intersectional lens. For those of you, I was an immigrant here coming from Asia, and so gender shows up differently in different cultures. And even here in the United States, there are microcultures within society. And so when we're looking at that aspect of intersectionality, how we approach providing information, providing resources, even encouraging self-help seeking behavior, that has to be done in a way that is resonant to those specific nuances that those microcultures have. And so one of the things that part of the reason the Center for Women Veterans exists is to ensure that, number one, we're looking at it from a gender lens across veterans benefits, veterans healthcare, and the National Cemetery Administration. But some of those disparities initially started because of that historical origin of the system. And so now we're trying to make sure that we are more reflective and responsive to the constituents that we have now. And then the last thing that I wanted to talk about is one of the biggest hurdles that we have, which then arises some of these disparities in provisions of care, which is we have over 2 million women veterans in the nation and across the world, because we have women veterans that live in other countries, whether they're mil vet spouse families, or if they are contracting in another country with the Department of Defense or what have you. So for whatever the reason, they might live in the territories or another country, but these one of our biggest hurdles is getting women veterans to self-identify as a veteran for a variety of reasons, right? There's aspects of, I just want to, pick up my uniform and I'm done. And this is one that I've heard quite a bit, which is, I didn't retire. I wasn't catastrophically injured. I wasn't working in the tip of the spear. I didn't serve in a particular career field that was considered front of the line. So for all of those reasons and more, many women veterans feel that they are not veterans because of that. And there's that self-stratification within the military system that, if you serve in the military, you kind of know. But this is one of the biggest reasons. So even with over 2 million women veterans, we are only reaching less than 1 million that are utilizing VA healthcare. And so there's a lot of opportunities that we still need to try to ensure that we are reaching those women veterans to get them the best and most economical care, honestly, for them to utilize VA healthcare. Let me pause there. That's a lot.
May I ask a follow-up? I just think that's an important question. If so few women are actually taking advantage of it, is it the communication that has to come first? Is it trying to find them, or is it the access itself? Because I do have a friend who is an Army doctor, military doctor at WIIS, and part of when I discussed it with her had to do with this access in rural communities for women or for particular kinds of health issues. So is it the communication? Both probably, but so dilemma is there, right?
Yes, and so it's a great question because I will say, and not being glib about it, but it is all of the above, right? Because there's different situations for everyone. when we're talking about even someone in rural, I won't even call it rural, right? I'll call it geographically isolated, because you can be in Puerto Rico and still be in a very urban area, but because you're in a geographically isolated island, the resources aren't there as if you were here in mainland United States. So I'll say geographically isolated in whatever fashion that looks like. If you need telehealth medicine, or sorry, if you need primary care and just need to do your annual talk to your primary care provider, we provide telehealth medicine, and utilizing the advances of technology now allows us to be able to better serve those in the geographically isolated areas. Now, the difference comes in when you need more specialty care that actually necessitates you to be at a facility. And that's where some of those disparities sometimes arise, because for many women veterans, and I dare say, I guess, women in society in general, if you have a family, the primary care provision is typically assumed by the women in that in family. So at least for us, one of the provisions that the Deborah Sampson Act provided is piloting the child care study. And so the addition of not only familial responsibilities, but if you're a single parent in a single income household, you have to then think about, do I work or do I take care of my health? And so sometimes that's a really impossible question to ask. And so some of these issues really kind of it's all of the above, I'd say, depending on what area you're at. One thing that I'll say is that we are leveraging a lot of technology in order to overcome some of these issues. The other thing is leveraging our partners, like EMD and in health service, et cetera, in partnership with some of those areas where we don't have a robust footprint.
Thank you very much. Would you like to provide some comments on some responses?
Yes, first thank you both of you for being here. This is great. I think I just want to underline that I think that Tracy's points and Laura's points really speak to each other, especially when we think about one of the great sound bites from Tracy's remarks is that there are more women in the Army than there are people in the Marine Corps, right? And that really demonstrates how women's role in the military has been changing over time, and that speaks also to that just connects, I think, really nicely to Laura's point about perceptions of oneself as a veteran and who counts as a veteran, and access or taking advantage of services and benefits that are available to you. And I would say that these comments really make me think about a few things. One is sort of thinking forward, the impact of demand and some problems with people not taking advantage of the benefits that they have on what's available, right? Because supply, to some extent, is always going to follow demand. And if demand is depressed below what it should be, then that means that the benefits are also not what they should be. And that speaks to, I think, really broader questions about inequity in healthcare and veterans' benefits. In some of the research that Tracy and I are doing, we've been surveying, that's related to this book but separate from this book, we've been surveying both veterans and active duty military personnel, and we've consistently found that women are less satisfied with military medicine than men are. And this, I think, is part of the reason why. And we've also found, and one of the arguments that we're making is that if you feel that you're being treated inequitably, then that has real effects on your morale. And we know that, especially in the military context, lower morale is going to lead to lower performance. So I think that's a really important set of issues that connects to what Tracy and Laura are saying.
Would you like to any other comments? Or
Goodness, boy, that was so loaded. About the bit from the paper that's out for peer review that talks about the importance of the military health system on maintaining morale for men and for women. I think if we look at what's been happening in the military health system, and you can't look at the news these days without learning about all the challenges we're facing. Just several years ago, there were headlines about the cutting of 18,000 military medical jobs and physicians, nurse midwives who deliver 30% of our babies, and that's like our number one product line in the military health system. Different techs that work across hospitals. So there was this looming threat of staffing cuts of active duty service members, where those positions were going to be repurposed to more warfighting billets. And then you look at, there were also, I published on this, they were looking at sending 180,000 plus beneficiaries out to the network and sort of booting them out of the direct care system, military clinics, and treatment facilities. And while none of those items have taken place at the scale, right? It's not 18,000, it's ramped back, and Congress stopped that. It wasn't 180,000 that has ramped back a little bit as well, but the message that it sends, the research that we did shows that people were watching, right? We used to say, there used to be like the meme, you had me at TRICARE, right? TRICARE is desirable, it's an excellent, it's an entitlement that functions like a health insurance benefit. And I think I paid $24 a month for it, but when we were at an active duty family, it was no cost to us. Imagine that if your health insurance, go home, if you don't have health insurance, talk to your family about what they're paying for health insurance each year. You know, it's a functional health system, a reliable and ready health system is essential to the strength of the nation. There's no national security without a robust military health system. And in terms of access to the VA, I think that in the days before the IDAS process, which I think really got going in 2010, 2011, 2012, 2013, where we tried to sort of roll back everyone that had gotten out in the 10 years prior. For a veteran like me, I got out it's a very long time ago, and I was healthy, I had health insurance. There was nothing that the VA had for me. So it didn't even occur to me that we were supposed to have a relationship for me as a woman veteran and the VA. And it wasn't that I served in a combat arm, I was Air Defense Artillery, but it never occurred to me until things like the PACT Act and the COVID vaccine. And then I was like, oh, maybe that melanoma that I had was related to my service. And when they tell the story of women's veterans and skin cancer, I wanted what happened to me to be counted. So I went through the PACT Act process. And then the same thing with the COVID vaccines. It's when it became available for individuals and caretakers. I dragged one of my children there, and I was like, he's my caretaker. Maybe yes, maybe no, but my kid got the shot and nobody in my house got sick. What do you think?
So one, thank you for using VA. But then number two, so I think the story that you said that you feel like you didn't need VA because you had nothing that you felt that was wrong with you, that you needed healthcare and you had another healthcare insurance. That's a very familiar refrain that I've heard from a lot of folks. But here's the thing. VA, well, number one, VA is not just healthcare. It's also benefits, insurance, and some care benefits. It is the only system within the United States that I know of anyway that follows you from the point of you departing your service, and even actually before that, if you use VA home loans or your GI Bill. It even starts before you leave your uniform, but follows you all the way to the end of life, and sees you through education, your different life changes. It is the only system that can follow you through your entire life cycle. And I think it's really unique, and it's also a differentiator of what the VA system does. Now, because of that, it's also extremely robust and very complicated. But the one thing that I'll say also, one of the things you said is, you might not need the care now, but you never know what happens in the future. Once you get into VA healthcare, you have it for life. And that's one of the things that I was talking about. We don't have a connection yet with all the rest of the women veterans who haven't even self-identified as a veteran for a variety of reasons. And because of that, they might think, like, I don't need VA healthcare. When I was in private sector, I had great health insurance, I was in tech. But I still chose VA because, number one, I had a great experience. Did not have a great experience many, many, many years ago. And then I gave him a chance again, so try VA again, because it's very different now than like 5 years ago or even 3 years ago. When I tried it again, I had such an amazing service that I actually had like 2 major surgeries. And I had a choice. And I chose VA because I built a trust with them. And that speaks to the part of access, right? Access sometimes isn't about being able to physically there. Access sometimes is that psychological thing of, do I trust my providers or the system to be able to provide for me what I need?
I could open it up to some questions that the audience may have, please.
So
Identify yourself.
I'm John Moreno, I'm a professor at Penn. I write about medical ethics and military medical ethics. So I guess this is a question for Professor Fazal. It seems to me there's a big historical, philosophical tension in leadership, dating back at least to the Second World War, probably before that, about the extent to which we as military leaders, the people who actually give the commands, have to be worried about what you're worried about. That is, our job is to win the fight. And, it goes to TRICARE in the modern era, it goes to VA, it goes to family a century ago to worry about what happens to these people afterwards. So, how would I as a commander factor in a question like yours? And mightn't I worry that political leadership, the people who actually tell me to go to the fight, might respond in ways that I wouldn't want when they understand what the real costs of this thing are going to be. And I'm not a frontline person in these questions. Dr. Cannon, my colleague, is retired, right? Surgeon, a surgeon, so he can address some of this as well. I wonder, isn't this an inherent philosophical problem for leadership?
So I think of this, I think these are great questions. I think of this as, the first part of the question in particular is, it's a political question. And it's really a question about not, I think there are implications for how wars are fought, but it is a question about whether you fight a war, right? Because if we think about the decision to go to war as a cost-benefit calculation, if we're systematically underestimating the cost of war, then our calculation is wrong, right? And so that, in the US, we have civilian control of the military. So this is really a political problem. This is something that politicians need to be made more aware of. And so that's the agenda that I'm making. So I don't see it, I'm not conflicted about it in the way that you described it. But I will say that I do think that a lot of times military commanders are maybe less attentive to medical issues and needs than they could and should be. And that, I think, is very problematic and actually counterproductive. Because in research that I've been doing with psychiatry students and research I've been doing with Tracy also, we're showing that there is a positive relationship between military medicine, quality of military medicine, and military morale and military effectiveness also. And you saw this, I think, really clearly in the start of at the beginning of Russia's invasion of Ukraine. And I think that there are implications, actually, for today of exactly this dynamic, where at the start of the invasion, especially, it was very clear that Ukrainian military medicine was superior to Russian military medicine. So, for example, a really key issue, and if you go to military medical conferences today, everybody talks about hemorrhage and stemming blood loss. And there are all sorts of new tools and strategies to address this problem, because it's the major cause of preventable battle death. And the Ukrainians were trained in the same way, they were trained by US forces using the same kinds of guidelines that US forces use and having some of the same types of equipment, like modern tourniquets. Whereas someone sent me, and you never know about the provenance of something, but someone sent me a video toward the start of the war of apparently, this person spoke Russian, I don't, a Russian officer training new troops on first aid, and it was a World War II era tourniquet. that was being used, and it was just a strip of rubber, right? And it really made me gasp. And this, I think, also has implications for the Ukrainians. It has implications for their morale, because you saw all these Russian troops saying, "We know we're just cannon fodder," and it has implications because there are many fewer Ukrainians than there are Russians, right? So it makes healthcare all the more important in that case. And I think it has implications for the kind of aid the U.S. should be sending to Ukraine as well.
And can I add, because work that I'm not doing with Tanisha, but work that my organization is doing in partnership with several others, is we've wrapped up. We're in the send the papers out for peer review phase of a huge study looking at what's happened in Ukraine since the Russian invasion. So we've looked at what equipment they have, what training they need to do. I don't know if you're teaching asset training at all. We've looked at that. We've looked at disease, non-battle injury, and how a patient transport with them. It was incredibly challenging research to get into their heads, the headspace of our 36 respondents, and learn what we can learn and what equipment needs they have, what training needs they have, and really the challenges they're facing in very prolonged conflict where they don't enjoy air superiority, where we all feel a bit idiotic if somebody says, "I'm the golden hour," in a meeting with them. We talk about, they would say drone evacuation, but we would say more remote piloted, ground tracked vehicle evacuation, and sort of these long, the tyranny of distance and cold and the inability to move, or these signals on the phone for telemedicine. It's been, I think that there are many lessons that we had from our 20-year war that are relevant to Ukraine, things that we taught them prior to the war. And certainly Ukraine, and because this is a Women's International Symposium, I think it's worth noting that Ukrainian women are right there with the men. I think everybody in the room is nodding in agreement that there's no real barricades. That we've interviewed many women, we've interviewed our sample included many men. 50% of the workforce for healthcare is women in Ukraine physicians. I don't know if you wanted to talk about that.
Just that VA is engaged in with a lot of our partners to make sure that we're providing as much information that would be helpful.
I may ask, apparently you also work in this field. Some of your impressions, what you think some of the hurdles are, where do you see us moving? Perhaps also, what is interesting is how Dr. Fazal's book shows the development, right, of innovation by necessity. And maybe this is another example of innovation by necessity in a very different environment, with drones, etc. But if I may just simply ask you what your feelings are, what your impressions are, and how, some reaction to some of the things we've been discussing.
Certainly. Well, thank you for the opportunity to chime in.
Please, yes.
Thank you for the opportunity to comment. By way of introduction, my name is Jeremy Cannon. I'm a trauma surgeon at the University of Pennsylvania. Retired recently from the Air Force Reserves, deployed 3 times, and I'm very interested in what we've started to call the peacetime effect, where the walker dip, where the capabilities really erode very rapidly between conflicts, and then at the start of the next conflict, our forward deployed medics, nurses, surgeons are unfamiliar with combat casualty care. And it's as if you're reinventing the specialty again on the fly. So I have an intense passion for addressing that and finding ways to mitigate that, together with colleagues like Danielle Holt, Eric Elster, Mark Boyer, many colleagues at USU. So that's my introduction. I have a question, and I'll certainly make some comments as well. I'm very impressed with your archival research. As an archive rat, I've been down in the dusty old basements trying to find these, and the dusty digital basements trying to find some of this documentation. So congratulations on all your incredible learnings and finds. Very, very impressive. Is there a point at which these individuals survive, and it's an outcome or a survival that's worse than death. Did you find instances where, for example, some of the extreme injuries from the most recent conflict would be a dismounted complex blast injury resulting in multiple amputations? Are these individuals able to live full and satisfying lives by their own definition? It's very difficult to know that prospectively. So, given Jonathan's expertise in ethics, where do we draw that line? Can we draw that line in a VUCA environment, a volatile, uncertain, complex environment? So I'll start with that, and then I have some follow-on questions as well.
But these are great questions. Thank you, Dr. Cannon. So let me just.
You need a
Okay, we can do that. You want to hold on, careful.
Okay, thank you, Dr. Cannon. So let me just start by saying that in the archival research, I actually found a lot of evidence of the Walker dip before the Walker dip was called the Walker dip. Right? So, for example, in World War II, you have military medical personnel who are unwrapping medical equipment with newspapers from the early 20th century, right? So the equipment has not been updated. And I will also just say that I too am an archive rat. That I had to restrain myself with the slides. But let me just recommend. This is actually available digitally. There was this one World War II combat surgeon named Henry Swan who went on to become actually a very prominent medical doctor when he returned to civilian life. And he was a beautiful writer. And his family had all of his letters home typed, and you can actually just access them online at the National Library of Medicine, and they're outside. I have some material about the book, and on the back side of it, there's a quote from him. Look that up if you want. But so, is survival worse than death? I mean, I don't think that I'm not a medical ethicist. I'm not that kind of doctor. My doctorate is in political science, not any kind of medical science. And so I don't think that I'm necessarily qualified to answer that question, but I will say that this is a question that comes up war after war and really is against the backdrop of the quality of medical science of the time. So, for example, after the Civil War, you had a proliferation of what were called empty sleeves because amputation was the most common. And there were actually, given the medicine at the time, we have this sort of impression of military medicine in the Civil War as leading to these buckets of sawed-off limbs, right? That's the stereotype. And there's some truth to that, but it was actually the appropriate medical treatment for the time. And so it did lead to all of these amputees, and I think a lot of them were asking themselves the question that you were asking. It actually had real gender implications for sort of the post-Civil War era, right? Sort of who does what kind of work. But I think that question, I mean, it is a question that I think kind of hovers over the book, but I don't think I can answer that. But I think that is a question that medical ethicists can answer.
There's a little data about people who survive multiple amputations, not necessarily in the military setting. And generally, people are remarkably adapted, and after some time, I'm sure you've seen this in practice, people are glad they're alive. It does raise a kind of acute clinical ethics problem, though, about how much you encourage, should we say, people to go for survival rather than ask for an intervention. But generally, people do adapt.
There's a question.
Well, my name is Ellen Milheiser. I cover Congress on military medicine. Funny anecdote related to all of this. Very early on in the Iraq and Afghanistan wars, folks in Congress noticed that, hey, a lot of people are coming back without limbs. And that led to a lot of discussions about body armor has improved, so people are surviving wounds that would have killed them earlier. There was one, I want to say very early on, 2004, 2005, with the service surgeons general and a whole row of very young men missing various body parts in wheelchairs brought over from Walter Reed. Senate Armed Services or Appropriations Committee, probably Armed Services. Bear in mind that at the time, the senators in charge of this committee included folks from World War II who also had amputations. First were the wounded gentlemen, and then they were in their wheelchairs off to the side. And then was a panel of the service surgeons general. During the course of his speaking, the Army Service Surgeon General, and I want to say it was General Peake, but I would not swear to it, turned to the side and said, would y'all be interested in a limb that we can link directly to your brain and you'll be able to operate it just by thinking? And everybody in the audience, including at the press table, are all like, oh, that's science fiction. And the service members said, yes, that would be great. And the Surgeon General said, we are working on that. But it's going to be a while. One of the wounded guys, I think he was 19, said, that's okay, sir, I'm young. Today, we now have artificial arms and hands that literally link to the same nerve in the arm that they just think and they use their hand. The reason I bring this up is your question of, is it worth living? Well, one of the things that military medicine is doing is answering this question of long-term survivability. You see it at the VA, you see it at Walter Reed, and it is science fiction. It is things that 25 years ago, 30 years ago, when I started doing this, it was unthinkable. And today, it's, oh look, what they've done. To ask another question, the long-term cost of war. You do hear about that in the Hill, and there are a lot of arguments about it with the PACT Act. Do you see the PACT Act as a one-off, or do you think that it will lead to a change in how Congress finances war? Because this is something the United States has to consider. Countries with universal health care do not, because their folks go back into the general health care system. And as a result, for example, the British cannot tell you how many people have PTSD.
So I think of, that's an interesting question about whether it's a one-off or will change things. I actually think of the PACT Act from a slightly different lens, so I'm going to give you sort of a sideways answer to your question. One of the really striking features of veterans benefits, especially since World War II, has been how much of a bipartisan issue it has been. But that consensus has really started eroding over the past 10 years or so. And historically also, it was really an issue that to the extent that one party had an edge, let's say, with respect to what was considered the party of the military or the veterans, it was the Republicans. But increasingly, what I'm observing, again, from my standpoint as a political scientist and university professor, it is that there's actually more support for veterans coming from, or more actively coming from Democrats. And so I wonder if there's and this is speculation, I haven't studied this, but my research makes me wonder, like one of the lingering questions for me is whether there's a little bit of a partisan realignment on veterans benefits. And I think that, I hope that insofar as there are students or people who might be interested in this question, I think that would be actually a really great research project for someone to take on. Tracy or Lawrence?
I just want to say we have about 5 minutes. We'd like to have some responses to that, because I know you've talked about the PACT Act, and then we'll ask for one last question or so.
So my sense is we don't see where either party is willing to make major reforms to reduce veterans' benefits. For example, the way that the body and illnesses are aligned with the IDAs and the awards process for veterans. We don't, that hysterectomy is worth, 50 or 60% in veterans' benefits. And maybe it's not as debilitating as it was when those benefits were first developed back in the 50s. Or the same thing with hypertension or sleep apnea, that some of these conditions might just be part of the natural aging process and are less linked to the specifics of an individual's service to the nation. However, in what I read and hear, I don't see that there's any political will to change this, although I'm sure it's been studied a great deal. So I don't see a will to reduce. I see motions to expand, like the Mission Act, like the PACT Act, that the VA appears to be trying to be more inclusive and to better support veterans, which perhaps matters in this time of poor recruiting, right? The services can't bring in enough young people for a variety of reasons. So this may not be the time politically, and this is absolutely not what I study, to reduce any benefits for veterans or discourage service in any way. I'm going to hand it to the expert.
I don't know if I call myself the expert, but so I'll stay away, steer very far clear from the political side of the house. But what I will speak to is the PACT Act expansion as a trigger for the expansion of services. We started this conversation talking about inequities and disparities in women's health and in women veterans' health and service women as well. And one of the things that I had seen, not only with PACT Act but also with the Deborah Sampson Act, is this expansion and acknowledgement of women's service in the military and looking at their service with the same gravity and seriousness as our male counterparts. That hasn't been done before in the past from a historical perspective, which is really kind of why we're here. And so when I think about PACT Act, it's a platform and a springboard to open up these conversations, because some of these presumptives that we have, I mean, some of them are very apparent, but some of them don't manifest until much later. Like some of those location based, so I was on a critical care air transport team with CCAT in the Air Force, and so I was part of those folks that were towards the front of the line, and I was in Khanabad and Afghanistan and all of these other geographies. And so some of these injuries or disease states don't manifest until later. And so what the PACT Act really opened up is for us to be able to look at not just what's going on with you right now, but also to consider what are the long-term effects of being in a particular geography or being in a particular career field that exposed you to toxic exposure. And so I think that when we are talking about the hidden costs of war, part of that is not looking at the immediate injuries, but what are the potential long-term that might not manifest until later.
We have run out of time, and I know we have a lot more questions, and I'm very, very grateful for a lot of the questions that we have already, and I'd like to thank, and please join me in thanking our wonderful speakers for their exceptional comments and for some of the information that they've given us, very important information. So thank you very much. And we'll continue our conversation. Thank you.
That was great. That's wonderful. Thank you so much.